Hello, everyone. It's another Vulval Pain Society research special. Welcome and thank you for joining us live or whether you're watching on the replay. Please say hello in the comments so that I know that you can see and hear me okay. Just a hello or a hi. So I know you can see me and hear me okay. And as we go along, is there someone there? I can see, oh yes, I can see. Brilliant. Okay, I'm seeing comments coming in, which is lovely on YouTube and Facebook. Fantastic. And as we go along, please pop your questions in the comments box as well as we go along. I am Sharon Gallbert, Vulval Pain Society trustee, pain therapist, clinician coach, and pain science educator. Now, we love researchers, and today we are going to discuss challenges and changes to identity in chronic pelvic pain with our guest, Lisa Pye. Lisa, hello.
Hi. Thanks for having me.
You're welcome. Lisa, you're a psychology PhD student at the University of Buckingham. Before we dive into presentation, and Winston DeMello, my fellow trustee, is there in the background as well. Lovely to see Winston. Now, before you tell us more about your research and the slides you have to share, can you tell us a little bit about yourself and what got you interested in pelvic pain and identity?
Sure. Well, I've had a bit of a gap between the traditional academic route in that I did a psychology degree a long time ago and then took a very different career path for a long time, during which time I did develop pelvic pain conditions, which affected the career choices that I made for a while. I couldn't do the job that I was doing and took on another job. And at that time, I had an opportunity to come back to study as well, and took the chance to do a master's in psychology. And within that, my research was around specifically endometriosis at that time and thinking about quality of life and what might be some of the factors that support quality of life. And how is it that some people, when they're living with conditions such as this, can continue doing all the things, seemingly do all the things they did before, and other people make significant changes, and what was that about? And it just happened to be that a friend of mine said, oh, maybe it's something to do with being a parent or something, and you've just got to get on with it. And it sort of struck a bit of a light bulb for me. And I thought, well, maybe that's something worth exploring. So in my master's, that's what I was looking at, and didn't really find anything there, but I had this sense that there was something more, there was something I hadn't quite figured out. So when the opportunity came along to do a PhD, I thought, well, this is what I'm going to look at. I'm going to spend some time properly exploring this idea that the roles that we inhabit and the things that matter to us, what's the impact of that on how we see ourselves when those things are challenged? So that's how I've got to where I am. It's a subject obviously very close to my heart, and I'm just so glad to have the opportunity to spend some time getting into it and seeing if I can find some things out.
Yeah, brilliant. And of course, I think you're probably going to cover this in your slides. We don't want anyone to think that as you are, your psychology is in PhD, that your PhD is in psychology, that we are saying that pain is imagined or in their head.
Absolutely not. And you're right, I am going to cover this a bit, but I think it's important to stress that understanding or exploring pain through the lens of psychology is absolutely not about saying, well, if you just thought about things a bit differently, everything would be fine. It's not that at all. It's about deepening that understanding of what pain is beyond a medical phenomenon and how we can increase understanding of the experience of pain, the factors that affect the experience of pain, in order to better understand how we can respond to pain and live alongside pain. We're absolutely not about saying there's any blame or gaslighting or anything like that. Psychology has I believe, a very good place, a strong place in understanding pain. And that's what I want to do, is to try and explore ways that we can help manage living with pain. when there's not a biomedical solution.
Yeah, brilliant. So should we dive into your slides?
Yeah, I'd love to.
Okay, let's pop these up on the screen.
Thank you so much.
Now, I know that's sort of off the screen a bit at the top, so let me see. So you can only see me now. It basically challenges and changes to identity in chronic pelvic pain.
There we go. That's great. So yes, so I'm at the University of Buckingham as a part-time PhD student, and the first thing I wanted to tell you about is actually the University of Buckingham, because it's very small and not everybody knows about it. We're actually one of the smallest universities in the UK, and we are the only independent university in the UK with a royal charter. So that makes us quite unique in some ways. But just because we're small doesn't mean we're not mighty, and I'm really proud to be part of this this university where there's some really good and interesting things happen. So, as I said, I've come to this university from a master's and now about halfway through my PhD. So what I'm going to run you through in the next about 20 minutes is a little bit about the link between pain and psychology and how psychology is useful in studying pain. But also I want to talk to you about what I've discovered about the link between pain and identity and how those two things might affect one another. And I'm going to do that through discussing the research that I've done so far and the research that I'm currently doing, as I do have a study live at the moment. And then briefly at the end, I'm just going to introduce you to some of what I think are the outstanding questions in the field, because obviously one PhD is not going to address this broad subject fully. So chronic pelvic pain, which I'm very broadly defining as pain in the pelvic area that's been present for 6 months or more, whether that be continuous or intermittent. And I know that there are different definitions of that, but that's the broad definition that I'm running with. We know from research that it can affect multiple areas of people's lives. For example, work. It can affect work in terms of both presenteeism and absenteeism, functional output as well. We know that it can affect parenting, it can affect people's social lives and friendships, and it can affect people's personal relationships too. Pain has been consistently, but interestingly not universally, associated with various aspects of negative effect, for example, depression and anxiety and anger. But as I said, this is not a universal relationship. And differences in the experience of pain and illness expression, so symptoms, duration, and functional impact, are present and are observed. And it might be that these are partly dependent on broader biopsychosocial factors. Now, the biopsychosocial model is not new and is probably very familiar to a lot of you, but it's worth reminding ourselves that pain and our health-related outcomes are not only determined by those physical aspects of our health. So a condition, for example, genetics, medicines. There are also social factors and psychological factors that determine or play a part in the way that our illness or pain influences our functional outcomes and our affective outcomes as well. In fact, there's quite a poor correlation between pain intensity and both functional and mental health outcomes. So it suggests that psychological and social factors might be involved in the way that pain is experienced. And this is actually good news for chronic conditions, because it suggests that in the absence of a biomedical solution, it might be that there are things that we can do in these other spheres that could have an impact on our outcomes or the way that pain or illness affects our lives. And as we said at the beginning, I'm in the area of psychology, and this is where my interest and my research lies. But this is something that's quite commonly misunderstood. So I do want to really reiterate this point, that looking at pain through psychology absolutely doesn't mean that we think that pain is all in your head. Absolutely not. exploring pain through psychology is about improving our understanding of those psychological factors that might help to minimize the impact of pain in people's lives. So it's not about blaming people for the way that they're experiencing pain. It's much more about acknowledging that pain is a biopsychosocial phenomenon and exploring whether there are ways that we can help people to adjust to living with that pain, as well as is possible when there isn't a solution for pain. So a moment ago, I noted that there are a number of impacts, reported impacts within pelvic pain on various different aspects of functioning. So let's think about how those impacts might relate to our identity. Well, identity theories are varied and broad. So I'm just going to read this one for you, which says that identities define us because they carry traits, personal characteristics, roles, and also ties to social groups. Identities can be focused on our past and the present and the future. So the researchers here, Dunn and Burkor, who've done a lot of work around disability identity theory, suggest here quite strongly that our sense of self does tie to our valued roles and our role functioning. And also our identity relates to our sense of social belonging and participation. So that again links back to that biopsychosocial model, and this understanding of identity is something that's multifaceted as well. But I also like this definition or this quote because it suggests that identities exist over time and that they can be aspirational as well as an actual current sense of who we are. So this suggests then that if pain impacts on the way that we function within our roles or our social relationships, this could have an impact on the way that we see ourselves at the current time, but could also impact on our anticipated future sense of self as well, which could be an additional challenge if our hopes and aspirations are threatened by our functioning. This has been explored theoretically through a couple of theories. And the first one I want to introduce you to is self-discrepancy theory. According to this theory, if somebody's actual self, so their sense of who they are at any given time, conflicts with their ideal self, so who they would ideally want to be, or their ought self, which is who others think they ought to be, then this can induce distress. So failing to fulfill a valued social role or the social expectations of others could be an example of such discrepancy. And over time, this might challenge identity. And actually, this has been seen in endometriosis, with mothers describing themselves as terrible when pain impacts on them being able to parent as they would like to, or actually as they believe that others think they ought to. So here is an example of a discrepancy between the actual and ideal and ought self challenging identity within the domain of parenting. Another relevant theory here is the schema enmeshment model of pain. Schemas are cognitive organisational frameworks that contain related information about different aspects of our lives. And this model suggests that we hold these mental representations, these schemas, both of ourselves, but also of our pain and of our illness. Now, when pain impacts on our functioning or our day-to-day lives, the pain and the self schemas become activated simultaneously. And what the model proposes happens over time when this happens repeatedly is that the information in those schemas therefore becomes enmeshed together. And over time, then pain, as you can see in the diagram in the middle of the slide where those circles are all overlapping, pain and illness information then becomes so enmeshed with the self schema that pain becomes that person's identity. And this has been seen in disability research, with enmeshment being associated with both disability and the mental aspects of quality of life across chronic pain. So these theories suggest then, alongside that definition of identity, that there could well be a link between pain and our functional outcomes and our affective outcomes and our sense of self. Looking at the research in chronic pelvic pain specifically, this has not been terribly widely explored, but there has been some qualitative research within endometriosis and within pelvic pain more broadly that has described challenges to sustaining our sense of self, challenges to parenting identity, partner role identity, and disruption to role functioning has also been related to poorer female identity. So this suggests that people living with chronic pelvic pain may indeed experience challenges to their identity. Managing identity challenges has been described as one of the main tasks of adapting to chronic illness. And we can see here in this quote, one of the primary tasks that individuals living with chronic pain must contend with is identity reconstruction. The limits imposed by pain and illness necessitate changes in what constitutes a valued sense of self. So this suggests that it might even be needed or necessary to develop a new identity in order to sustain a positive sense of self in the presence of ongoing pain. But at present, within chronic pelvic pain, there's very little to describe how people experience or how they approach managing challenges to identity, even though those have been noted as being evident. So my first study was set out to address this gap by asking that very question. How are challenges and changes to identity experienced in chronic pelvic pain? And this is a study I conducted at the beginning of my PhD about 18 months ago, where I did some online semi-structured interviews with adults living with chronic gynecological pelvic pain, but who were not living with any other significant pain conditions. Recruitment for this study was kindly supported by a number of charities and groups, and my data was explored, analysed using a process of reflexive thematic analysis, which is a method that allows exploring patterns of shared meaning across a data set. So looking at the data as a whole and seeing looking for common threads and commonalities amongst what the participants were saying. From that study, 6 themes were developed that explored identity, challenge or change. And this thematic map shows the titles of those themes and how they might link together. Now, in some of those themes, it was evident that people were expressing an impact on their identities from living with pain, just as those theories, the self-discrepancy theory and the schema and measurement model of pain, might have anticipated. But the theme constructing a meaningful future that I've ringed at the bottom there described instead a determination amongst some participants to find ways of living alongside their pain without it dominating or overwhelming their identity. So I'm going to very briefly talk to you about that theme for a moment. So some participants described striving to come to terms with pain-related disruption and reflecting on what it means for their identity. So the quote from Kelly there, she said, "It comes back to managing expectations. The goal is to have a pain-free life and live life like I used to. Well, that's probably not going to happen. So what's the best case scenario realistically?" So for Kelly, it seemed that accepting that her pain wasn't going away had started to enable her to think about what a meaningful life might look like despite this. And this was also echoed by Bryony, who said, "You need to learn what sort of person you could be with this illness and try to make the most of it." So this implies that there might possibly be a role for acceptance-based approaches in supporting identity-related challenges in pelvic pain, but this isn't something that's been widely explored. Now, importantly, constructing a meaningful future as a process was described as a conscious aim, but something that is effortful. But the participants that spoke of this suggested that it was important for their emotional well-being and being able to move forward. Part of this may be recognizing or accepting that a previously held ideal self might be unrealistic. For example, Ella said, there's a version of you that exists at the moment that's perfectly fine, and I'm holding on to archaic ideas that are probably socially prescribed anyway. And maybe that's the moment I start to look at those as the things to fix and not me. So Ella's words here suggest that moving away from what she termed a socially prescribed ought self that she can't meet any longer, and adapting her ideal self to incorporate the pain-related restrictions that she's living with could help to resolve some of those distressing discrepancies and enable her to construct a positive and meaningful future. Broader chronic health research has suggested that receiving a diagnosis can help with this. It seems that it's possible that having a diagnosis almost gives permission to begin moving away from persistently seeking for a cure to beginning to find ways to work alongside chronic illness and to construct best possible outcomes in light of that. And this is obviously a significant problem within chronic pelvic pain because, as we know, very many people never receive a diagnosis for why they're living with pain. So to briefly summarise my first study then, it did seem that challenged role functioning can challenge identity, either due to a perceived failure to meet their own expectations or the expectations of others. There does seem to have been some evidence of a discrepancy between who the individuals want to be, who others think they should be, and their reality. And across the themes, there seemed to be a tension between trying to sustain a former self, to trying to maintain that sense of who you are, but also trying to adjust and reconstruct the sense of self and identity in order to move forwards in a positive and meaningful way. And as noted before, acceptance of pain did seem to be a common narrative here. So moving on to study 2 then, the first study suggested to me that further work is needed really in understanding how responding to identity challenge might be supported. For example, an improved understanding of whether there are factors that could support that process is definitely needed. But even more importantly, what's needed is a bit of an exploration of whether there is, in fact, an optimal response to identity challenge. Whether it's better to try and to sustain a previously held self, or whether identity redefinition, as that quote suggested, is actually a better way forward. And research in this area is quite mixed, actually. So there isn't anything really in pelvic pain on this, but in other pain research, it's suggested that sustaining goal-focused behaviour, so role-consistent behaviour, for example, such as persisting with work, those things in some research are shown to help promote identity stability and also to help sustain an identity outside of pain. But other research has challenged this and suggests that actually developing an integrated identity where pain-related information is incorporated into identity but without overwhelming or defining it like is seen in that schema enmeshment model, that sort of response to identity challenge in some research has been associated with positive health outcomes, functional outcomes, and affective outcomes. So my priority then for my second study, which is the one that's currently open, is to find this Goldilocks zone, asking the question, when is enmeshment not enmeshment? So, to what extent do identities need to change and juggle? So a little bit of background to start off before I describe my current study. This was inspired by a research in multiple sclerosis, and researchers in this area have developed a scale called the Identity Reconstruction Assessment Scale here. And their measure suggests that when people are responding to identity-related challenges in chronic illness, They may strive to sustain a former sense of self. They may become defined by their illness, or they may find a way to incorporate illness information into an integrated identity. And the researchers set out to test this model, to test this scale, and to associate, to see if there were associations with a variety of psychological and other factors, to see really if any of these outcomes were more favourable than the others. These identity factors were more favourable than the others. And this model's not actually been widely tested outside of this study. And there was, as I said previously, there is some inconsistency in this area. So it seems that this is worth exploring. There were also some potential issues with sample sizing in this study, which may have slightly influenced the results. And the authors, of course, called for it to be used within other populations. So this was really convenient for me, really. There was a measure here that needed testing, and I'm really interested in this area. So I've employed this measure into a partial replication study where I'm looking to explore whether or not one of those identity redefinition factors is more favourable within chronic pelvic pain, or if they're equally favourable. Also interested in exploring whether those identity factors associate with a range of other psychological factors, and to confirm whether the three factor structure of that measure as well. I'm also interested in finding out whether the outcomes, reported outcomes, would be consistent between people who only have pelvic pain and those who are living with other pain conditions as well. As we know, comorbidity is very common, both amongst pelvic pain conditions and between pelvic pain and other pain conditions. And if I get sufficient data, I'm also interested in seeing if there are differences in identity change outcomes between people with and without a diagnosis. So this is what I'm working on at the moment. It is a quantitative online survey for any adult living with gynecological pelvic pain for 6 months or more, whether that's diagnosed or suspected. And as you can see, I've been kindly supported again by a number of pain groups and charities who've kindly shared the study recruitment advert with their networks and followers. So this will be a quantitative analysis here, a factor analysis of that IRAS scale to see if that three-factor structure can be confirmed, and some regression modelling looking for associations between different aspects of identity change and various psychological factors. And as I said, it is still open. So if anybody is interested in participating, there's a QR code here, but there's also a clickable link on my bio on Instagram, and I believe as well on the Vulval Pain Society website and Instagram page. And I do thank you for your support with this. It's very much appreciated, your help in recruiting participants here. The study takes about 20 minutes. It's voluntary. You don't have to give any identifying information. There's an option to give an email address if you want to be informed about future research, but you absolutely don't have to complete that at all. And if you start the survey and you decide it's not for you, you can just close the window and your data is not saved at all. So it's very flexible. If you want to have a look and think about whether it's for you, you can explore and go back to it as many times as you want to. But as I said before, one PhD is not going to address all of these questions, and there will still be some outstanding questions at the end of my study. For example, it definitely needs some more exploration of how, sorry, my laptop's just doing funny things now. Excuse me. There we go. Oh, there we go. Sorry, I've lost you for a moment there because my laptop's decided to try.
We can still see you.
Oh, that's okay. Thank you very much. I'm sorry it's pinging away. It's telling me off. Yes, so outstanding questions, for example, how might diagnosis facilitate the process of adjustment to chronic pain? Is that relevant? Is it not relevant? If there does seem to be a difference between people who are diagnosed and not diagnosed, then there's some interesting questions about whether reducing stigma, for example, through improving education, might support people in accessing healthcare for increasing understanding, social language around talking about pelvic health and whether that might enable people to seek help, whether that might improve diagnostic rates. And then finally, it could be interesting to explore whether identity challenge management within chronic pain can be supported, perhaps through psychological intervention or support. This is something that I think is possibly worth exploring in the future. So I want to just leave you with a quote from one of my participants, Lydia, who said about her pain, "It's not me, and it's not what makes me me." And I really loved her words there, because despite what might have been expected from self-discrepancy theory and the schema enmeshment model of pain, for many people, there's this intentional rejection of pain as a defining feature of who that person is. And I think that improving understanding of how people go about navigating challenges and changes to their identity, so that Lydia's statement could be true for everyone, is really needed. And that's where I'm going to leave it today. Thank you so much for listening and for the time. And I'm interested if anyone has any questions. I'm happy to answer if I can.
Lee, that was brilliant. Thanks, Lisa. We've got a question.
Oh.
Is the ultimate aim to actually reduce pain levels or to improve mood and psychological coping with and living with the pain?
It's a fantastic question. And I think that is different for everybody. Interestingly, as I said before, there's quite a poor correlation between the amount of pain that people report and the amount of impact that pain has on their lives. So there does seem to be associations with various aspects of mental health and coping styles and things like that, and the level of reported pain impact. It's a tricky one because obviously, ultimately, we want people to be as pain-free as possible. But we also know that that isn't always going to be the outcome that we see. So finding ways of improving the things that support living with pain, I think, is an important avenue when we don't yet have a way to resolve pain. So I realise that's a little bit of a non-answer, but I think from my perspective, trying to find ways that people can live better or live more successfully is not the word I'm looking for, but for people to feel that they're living positively or as well as they can with their pain until such time as their pain can be resolved. That's sort of where I'm going.
Any other questions? And as people are having a little think as to whether they have questions, you were talking about this different roles. So the role that a person might want for themselves, so their values-based goal or role, the role that society might put upon them, and then how they are in the present. So this discrepancy between the three. And I'm wondering, the experience of some people when they go and see a clinician, perhaps not a specialist, but prior to that, on the way to perhaps getting a diagnosis, is sometimes being treated as a body part rather than as a complex human being. So you're talking about the biopsychosocial model. Biopsychosocial is not just psychological, it's biological, psychological, and then societal values, norms, and all of that, and our place in society. So all of that. So I wonder if we can talk to what that might mean for someone who turns up, because this is really important, isn't it? Someone turns up and is treated as a body part, is going to play around with their sense of self, would you say?
Quite possibly. I think certainly within conditions such as endometriosis and adenomyosis, there seems to be, people report when they go to see their healthcare provider, there seems to be this metric of fertility being the priority. And obviously that is a priority for a lot of people. But actually, if that's not what you've gone to see your doctor for, and that's what is discussed, that's quite disarming, because that then raises a discrepancy between, well, this isn't what I'm asking you about, you know, this is not why I'm here, so why is this what you think is valuable, you know? So there's a question of metric there, and I think understanding that communication between a patient and a clinician about what is my priority, what am I here for. So I've slightly gone off track. I realise what you're saying. I've lost slightly what you're saying. But yes, exactly. So being understood about this, trying to get across this point about this pain is impacting my life, and having those concrete examples of, on these occasions, I find it difficult to do these things that matter to me. This is impacting my quality of life. This is affecting my social relationships. This is affecting this area of my life. I think it's important to communicate the impact of pain rather than just it hurts in this area on a scale of 1 to 10. Pain impact, I think, is, and that brings that into that role functioning, I think. Having that prepared before you go and speak to your clinician, I think, is quite an important thing to do.
It is, but of course, if someone is experiencing pain, what they're probably going to is, I'm experiencing pain in this area. Can we solve this? Can we do something about it? And if the clinician can come from a viewpoint of what else is going on in this person's life and what is important to them, it helps along. Yes, it would be great if we go prepared to the GP, to a clinician. And we do have on our website a form that you can fill in for yourself to prepare for gynecological appointments, which you can tailor for any appointment. So I would take a look at that, so you know you are prepared. But if clinicians can do that too. Winston says, how a diagnosis and acceptance can be helpful for chronic pelvic pain patients was my take-home message. Exciting research. It is exciting research. We have discussed acceptance and commitment therapy before. Claudia Cesari has done a couple of live streams with us that you can look up, not just yet, but on our YouTube channel and our Facebook pages. So do seek that out later. We'll share the link with you a little bit later on.
Yeah, I'm very interested in that with the acceptance and commitment therapy. Obviously, there's this narrative of acceptance that was coming through in my first study. And I think if there's a role for acceptance in managing identity challenges as well as broadly pain acceptance, and I think that's a really exciting avenue. If there's potentially a tweak or an extension in there that could be applied, it would be that would be exciting.
Yeah, and of course, when we say acceptance, we're not saying giving in. It's just stopping a war.
Yeah, exactly. So, and I think that is, as I said before, this misunderstanding of psychology. That word acceptance can be really problematic, because it does come across, if you're taking it out of the psychological context, it comes across as saying, well, you've just got to put up with it, and that's not what that means. So yeah, thank you for raising that.
What have we got here? There's also the possibility of actually reducing the physical pain by coping better with other sources of psychological stress.
Yeah, definitely. Yeah, that's supported by evidence too. Yeah.
If anyone's interested in that, we did one on pain the brain and calming the nervous system, where I talked about what is happening internally inside the body. And yes, absolutely, it's not just about the pain you're experiencing, can be amplified by other factors and what else is going on in your life as well. So yeah, absolutely. Pain is something that I have, but I am not my pain.
Brilliant. Yeah,
absolutely.
That isn't the case for everybody.
And it's, you're talking about enmeshment and kind of just, actually you're talking about schema and how they can overlap. So your sense of self with the illness schema and the pain schema, how over time they can just kind of overlap and get enmeshed together. Do you have ideas of this may be beyond your scope, I don't know, of how that might be separated out. Was that what you're hoping from your research? You can discover ways of how they can separate out again.
There is a little bit of work in this area, not in chronic pelvic pain. There has been some suggestion that reducing enmeshment seems to diminish the impact of pain on people's lives. I don't have a reference for that off the top of my head. I can't quite think where that paper could be found. I don't know if its enmeshment has been explored alongside acceptance and commitment therapy, because that would be interesting to see whether going through that therapeutic process might help to reduce enmeshment. I don't know whether that data is there. I hope that would be a good thing to look at, actually.
What are you hoping from this? And we've put up the link to the survey, and I'm not saying go away and do that straight away. How long did you say it would take to complete?
About 20 minutes at the most. It's not terribly long.
Okay. And we will share the link again afterwards and on our socials. So, complete it when you have 20 minutes. If someone completes, did you say that if they complete part of it and then they want to come back to it, does it save for them to do that, or do they have to do
No,
one go?
you'd have to go back again. If you don't get to the end and click finish, then your data's just not saved. So, but what I meant is if you want to have a look at it and have a think about it, you could do that. You could have a look, see if you think it's relevant, close it down, and then if you decide to come back, you could come back and fill it in.
How are you hoping this is going to help people with your research, your survey? And we can see where you want to go with things, but how do you think it's going to help people living with chronic pelvic pain?
Well, I'm hoping in the long term that it might inform some kind of intervention or support or therapeutic approach. I mean, this is well beyond where I am at the moment, obviously, as a PhD student. But what I'm hoping is that if we can find a way to enable people to put things in place or to make some little changes or to get some support that helps to manage this identity challenge aspect. And as I said, it might just be a tweak to something that's already there. It might just be an increased awareness of this is actually something that I need to manage, or I could get some support with managing. Then I'm hoping that might make a difference in time to come.
Okay. You also talked about looking at whether there's a difference between people who receive a diagnosis or they've yet to receive a diagnosis. Can you just talk us through that part?
So there's some interesting research from Bronnie Lennox-Thompson, talks about diagnosis and talks about how it seems to be, and this is pain more broadly, not chronic pelvic pain necessarily, it seems to be that having that validation or legitimacy, that it's actually a medical condition. It's it's not just there's something wrong in my head and that's why I'm living with this pain. It seems to be for some people a point at which they can say, okay, right, well, I know what it is now, so now what do I do about it? Because I think often for people living with pain, there's that need for validation, there's that need for understanding, but there's also this desperate chasing for something that's going to make it go away, because living with pain is horrible. So it seems to be that step away from, well, I know what this thing is now, and I know that actually at the moment it's not going away. So now it's the point where I can start to work out what I do with it. So that's where I think diagnosis can be helpful. I'm interested to see what the data says about that, whether there are differences between people with or without a diagnosis. But it seems to be, Bronnie Lennox-Thompson talks about it in terms of permission. It seems to be this permission to say, okay, well, I don't need to fight this thing anymore. Now I can go about exploring how I move on with this. So I'll be interested to see if that's reflected in what I find.
Yeah. And that uncertainty, when we are uncertain about anything, and we talk about when there's a hit of adrenaline, we're uncertain about something, but hit of adrenaline, first muscles that tense up in the body are the superficial pelvic floor muscles, followed by the jaw. So we know that there could be another level of amplification, if you like. Do check out Bronnie's blog, Health Skills. If you're watching this and you're not already reading her blog and you're interested in pain research, and she puts it in really nice, clear language, do look up Bronnie's blog, Bronnie Lennox Thompson. Anything else you wanted to mention?
No, I don't think so, really. Obviously, I'm well aware that I'm a student and I'm at the beginning of a journey and exploring something that's quite big. And I'm very well aware that I'm not going to answer all of the questions. I'm very well aware that there are multiple different directions that this research could go in before I even get to the end of my doctorate. But I am really excited to have the opportunity to take something from my own experiences of pelvic pain and to find a way to, even if it's a drop in the ocean, I'm glad to have the opportunity to do something. And I'm really excited and inspired by the work of your charity and other groups and charities that are speaking out for people living with these kinds of pain, and particularly with stigmatized and invisible pain. I think it's brilliant to see that there's things happening.
Yeah, and absolutely reducing the stigma so that people might feel they can go and access care. So important, the work that you're doing. We're really looking forward to seeing the results, which means if you're watching this, we'd like, if you are experiencing pelvic pain, vulval pain of any kind for 6 months or over, and this is for adults over 18.
Absolutely.
Yep. Then please, take 20 minutes and fill in the survey. This can, change the way we treat vulval pain, pelvic pain, looking for better outcomes in the future. So, please, everything you do makes a difference, if you can, of course. Thank you so much, Lisa. That was wonderful. We will share your survey link again across our socials. And of course, if you've joined us late, you can rewatch this live stream or any of the previous ones that I've mentioned, or this whole host of things. Past Facebook events are on our Facebook page. Our full playlist of almost probably about 50 videos now, 50 live streams, webinars with different vulval pain expert clinicians, researchers. They can all be found in our YouTube channel. And Marion Jones has rocked up and said, I will have to look at this live again. Please do. Check it out on our YouTube. And I'm just going to quickly just paste up that link for YouTube as I'm talking. There we go. Actually, what I posted up is a 2021 playlist. I'm so sorry. But it will take you to our 2021 playlist. If you can go on, you'll see our YouTube channel. It has about 50 videos on there. And we've covered probably everything you might think of regarding vulval pain treatments that are credible, vulval pain treatments and management. And, as well as with researchers like Lisa, we've had clinicians and also expert patients and self-management, supported self-management, of course. So go and check those out. And if you can pop those links up, that would be great. Listen, whether you are a specialist healthcare practitioner or you live with some kind of vulval pain, we run these events for you. So if there's an expert clinician or a researcher or a topic that you find that we haven't covered yet, or perhaps you'd like us to cover again, just let us know. The easiest way would be via email. So info@vulvalpainsociety.org.uk. Or you can reach out to us on our socials, so Facebook, Instagram. We are a tiny, tiny team, so we haven't always got our eyes on our social media, but we will get to them. If you have any ideas, anyone you'd like to see, or anything you'd like us to cover for the first time or again, let us know. In the meantime, we thank you for sharing our videos and posts far and wide with anyone you think can benefit and anyone who needs to hear. You'll find us, as I say, on Instagram, Facebook, sometimes on X. We might not be using it so much. Let's see. As always, when you share our posts and videos, you are helping us help more people living with vulval pain and the healthcare practitioners treating people living with vulval pain. So thank you so much. We have lots of resources too on our website. So
vulvalpainsociety.org.uk.
Keep an eye on socials, as we are organising another live for you before Christmas. Those details will be revealed soon. Our details, so YouTube, Facebook, Instagram, all of those details will come up on your screen once I get our heads out of the way, Lisa. The survey link we will share again. That's it from us today. Thank you again to our researcher, Lisa Pye.
Thank you so much for having me. It's been an absolute pleasure and really exciting to come and share a little bit about what I'm doing. So thank you.
We can't wait to have you back for the results of this survey as well, and what might come afterwards. So yeah, brilliant. Listen, thank you all for being with us live or on the replay. Bye for now. Keep in touch. The detail screen is coming up, so see you next time.